everybody. Now the stakes are raised. I'm really excited to be here with you all. I'm actually going to start by talking about my role as an epidemiologist. I have a picture of Maria Gleamore here, who's at the conference, because she asked me about 10 years ago, why are you an epidemiologist? And I've thought about it a lot since. It's a strange question to ask somebody after about a decade of training to become an epidemiologist, but the question did help me think about the way I approach my work. And specifically, she asked me about why I was an epidemiologist and not a sociologist. For some context, Maria and I both did a 2-year faculty training program, the Robert Wood Johnson Health and Society Scholars Program, that was very interdisciplinary. We had sociologists, anthropologists, ethnographers, epidemiologists, and all of us researched health and population health in particular. Most of us had an interest in questions of health equity and differences in health that we thought came from kind of unfair structures. And you know, there were a lot of sociologists trained as health demographers who also did similar work as I did. And so my answer to Maria was basically that I personally appreciate the discipline of being grounded in a practice-based and intervention-oriented field, which is how I see epidemiology as part of public health. And so at the risk of getting on the bad side of my sociologist friends, I will say that I feel like my sociologist colleagues who do similar work lean towards developing and testing more sweeping theories, which I love, and my work is informed by those theories. But sometimes they can be a little unbothered by some of the details and the messy deviations from theory. But in a practice-oriented field where the possibility of action, translating knowledge into action to improve health is your guiding star, the complications can't be ignored because they will arise one way or the other if you're really trying to do intervention-oriented work. And the practical aspects of the research can't be ignored. And so I'm an epidemiologist because I find the orientation to intervention and practice to be very grounding, intellectually challenging, and a discipline that pushes me in my research. And so this will keep coming up as I talk about what do I think are kind of my 3 big jobs as an epidemiologist. And for me, they are to choose important research questions, to ask specific questions, and to do analyses that answer those questions. And so each of these is a little bit more complicated than they might appear on their own. And so I'm going to talk about them a little bit more in the context specifically of doing work to try to understand racial ethnic differences in health. So now I'm changing the question specifically to my job as an epidemiologist who studies racial and ethnic differences in health. I'm very much grounded as an epidemiologist, but most epidemiologists ask questions of the structure, what factors X cause outcome Y to be higher in a given individual or population? And you know, these are important questions. There are different kinds of questions that can be asked, but when I work in racial ethnic differences in health, I add an extra layer onto that. I'm still doing that work, but now I'm adding an extra layer of explaining the group differences in, you know, the population characteristic as a function of that exposure. So almost all of my questions that I ask are of this particular form: what factors X cause outcome Y to be higher in group A versus group A2, you know, A1 or A2. So it's kind of a layering and a more complex set of questions. And so as far as choose important questions, I wrote this one because I think in any research career, there's a range of questions we can ask. I know that seems self-evident, and I think we often even think, why do I study this and not that? But when you pick a research area, I think it's important to make an informed choice about what you're studying and to incorporate a wider set of potentialities into the work you choose to do. If we're trying to do work that we think has translational potential, there's a huge range of potential intervention points in all of our work. And I think, you know, for somebody like me, I think what is most likely to yield actionable solutions. And I'm not saying this to try to limit the scope of what people do to things that seem politically palatable or things that seem imaginable. I really do think that we need a big, bold, counterfactual imagination with the work that we approach. But when we think about racial difference specifically, there is a history of having work that's very limited to a particular area. So one of these theoretical orientations that's under a lot of health disparities research historically, especially for Black-white research in the US, has been genetic determinism. Kind of a sense that any Black-white difference we see is because of some germline genetic difference that is kind of invariant between Black and white people as a rule. And I think having a tunnel vision where that is the kind of question you think that is how you see the world, it's just going to lead you to ask a very narrow band of questions. You might really be thinking, I really want to make the world better. I really want to understand these racial differences. But if you are totally grounded in genetic determinism, you are only going to pick a certain type of questions. And it precludes you from asking more important questions because you don't even know the more important questions exist. And so I myself, I'm a person who tends more towards social and genetic explanations while also knowing social and environmental explanations, while also trying to be very aware of the range of possibilities, the range of possible explanations, so that I can make a very informed choice for what I choose to study, and also to understand how those other factors intersect in my interpretation of what I actually am doing. I think I had another point I wanted to make. I should shout out Nancy Krieger. I think Nancy likes, being like, talk about her focus on embodiment, which really does bring into the idea that the social and the environmental do get under our skin, get embodied with us. And there's not a conflict between thinking about biological mechanisms and the social environment, because they really do come together. I think that's what I wanted to say here. I'm sure there's something else. So besides choosing your question, which is already a monumental task, then you have to translate that into something specific. And so part of what we did in preparation for this talk is we watched Maria Gleamore's video, I think maybe from last year, about causal inference. And causal inference is so important in our field because we want to do things that make a difference. If I just say X is associated with Y, but I don't know if that has any bearing on whether changing X would change Y, at a certain point, it's like, well, what's the point? To be grounded in an action-oriented field is to care about causation. And so one of our paradigms for that is potential outcomes. It's not the only paradigm you can use for understanding causation, but it's a powerful one in the kind of work I do. And one of the things you have to do if you're going to use that paradigm to try to understand causation is to ask specific questions. So on this slide, I have a meme from Seinfeld. For all of those who are not Gen Xers or around there, Seinfeld was a very popular television show in the 20th century. And there was a meme at one point about how the group would say yada yada to avoid getting really specific about something they didn't want to talk about. And so it's a funny episode. And so in this slide, Jerry is saying, talking to Elaine about something, he's saying, but you yada yada'd over the best part, And they start using this as a tool to be like, and then I did this and yada yada, and then it was the next day. And so I think sometimes, especially with people who are entering into the field of racial ethnic disparities in work, sometimes their questions are really vague. They might say like, well, I want to account for race, or I want to account for this thing, or I want to look at the role of this. And sometimes the framing expresses a desire and to do something about a topic and a knowledge that this is important, but it's not specific enough to ask a research question that is testable. And so I think trying to be precise in the questions we ask is really important. I think it can feel pedantic, and sometimes it can be taken to an extreme to really narrow the scope of the questions we ask to things that seem to fit into a very narrow, maybe experimental context. And I'm not an advocate for that. I think that there is a way to think about counterfactuals in a very broad way, not just intervening on the individual, but on society. But I do think being able to be specific about the question you're asking helps make research more impactful. And finally, once you have your question, you've decided this is kind of where I want to go with my work, and this is the specific question I want to pursue. The next thing is thinking about conducting research, building a study design and analyses to actually answer that question. And in the next part of my talk, where I go over the paper that was associated with my talk, I'll get more into that. But I think in the same way that sometimes we don't express questions in a very precise way, sometimes we do analyses where all the kind of variables or interests are there, sometimes they're not even there. But even if they're there, you still have to make a decision about what you do with the data and how you interpret it. There's so many cool methods out there. So I kind of stole this word cloud from somebody. There's so many different kinds of data you might use, different choices you might make about who goes into your sample, different methods. And I think sometimes it's important to step back and think about, okay, what is the approach I want to take to answer the specific question that I think is important? And so in this paper that I did with graduate students, Julia Ward, Danielle Gartner, Elizabeth McClure, and Mike Fliss, and also with my Columbia colleague, Carrie Keyes, we thought about that. We thought about how do we think about stepping back to make sure that our analyses actually match our questions. And a key thing was how we saw a lot of interaction terms being used with race ethnicity. And so I'll get into that in more detail. But we posed 3 questions to help orient those who might be interested in identifying causes of racial disparities in health, who might be interested in that kind of question. Is factor X causing a higher burden of disease Y in population A1 versus A2? And so for the talk, I'm going to focus in on one part of the paper to really use as an example a paper we cited from the American Journal of Hypertension in 2013. And I just want to make it clear that I'm not singling out this paper because I think it's especially bad. I think it's like kind of very common how they approach their data and interpretation. I picked it because they were very explicit about the analyses they conducted and the strong recommendation they made based on their findings. But I think many other papers do this. They just happen to be one who was very clear about how they got from their data analysis to their recommendations. So the authors were using NHANES data to address the following question. Among people with hypertension in the US, how does having diabetes affect the odds of having uncontrolled blood pressure? I am not a CVD person, so I don't know how important this question is, but that was their question. And from these results, which I'll dissect a little bit later, the authors conclude in the final sentence of their paper that, quote, in clinics, health providers need more efforts to weaken the association of diabetes mellitus with uncontrolled blood pressure outcomes by further improving care for diabetes and blood pressure in non-Hispanic whites. Now, this is a kind of an eye-catching recommendation. Even not being a CVD person, I know that the burden of CVD is like much greater in some racial ethnic minorities and white populations. And the idea that health providers, based on this study, that health providers should be focusing more attention on improving care for diabetes among white Americans while maintaining the status quo among Black and Mexican American patients was an unusual finding to come. And so one reason is that many health disparities research, and so kind of let's step back and think about the whole frame of like health disparities research. There are many different terms in this field. You'll hear about differences, inequalities, inequities, health disparities, and even their different definitions of the same term. So when I talk about health disparities and even health equity, I'm really drawing mostly from Braverman's definition, in which it's a difference in which disadvantaged social groups, such as the poor, racial ethnic minorities, or sexual minorities, systematically experience worse health than more advantaged social groups. Social advantage refers to one's relative position in the social hierarchy by wealth, power, or prestige. And so, to have this as an orientation and then to recommend the status quo for socially disadvantaged groups and improving care for more advantaged groups, it's not really like a health disparities kind of approach. But even more, besides kind of the theoretical implications of their work, I think the authors might have come to a different conclusion if they considered the set of empirical questions that I'll propose in the next slide, which is kind of the basis of our paper. I think they might have come to a different conclusion because they would have realized their data did not actually logically lead to their conclusion. And so the questions that we proposed in this paper for intervention-oriented disparities work, where you actually do want to interpret things in a way that helps you understand causation and what might improve health, especially for socially disadvantaged populations, we kind of propose 3 guiding questions that we think any researcher can ask when they're trying to understand what their data have to say about the causes of racial differences in an outcome, or what intervention would make the most sense if you are interested in making group-specific recommendations for targeting. Answering these questions does not require computationally intensive modeling. Instead, they're basic questions that are accessible, I said, to any practicing epidemiologist, but I think anyone in this field who wants to do this kind of work. I personally have a strong belief that simple descriptive analyses and even pretty simple regressions can get you 90% of the way with most things if you're asking the right questions. And it really depends on framing the right questions and having the right data and doing correct interpretation. So the first question I say you should ask if you're interested in understanding racial ethnic differences and you are working within Braverman's kind of health disparity framework where you consider positionality and systems of advantage, the first question would be, is there more disease burden in the target group, which we usually consider the socially disadvantaged group, but you could apply this broadly, versus other groups? And this is bread and butter epi. Maybe we propose this because we are such epidemiologists. What does the surveillance data say? Like, how is this disease burden distributed in the population? Is a great question to ask when you want to start thinking about population differences. So again, this paper recommended targeting non-Hispanic whites for improvement of care in their diabetes. And so someone in a health disparities framework would ask, is the disease burden greater in this group that is proposed to be targeted? Now, the authors were using NHANES data from 1999 to 2008. And a great thing is that that is publicly accessible data. So we could just recreate that. We could answer it actually from things they put in their publication. And sometimes you will have to seek out external surveillance data because it won't be as evident. But here, it was really easy to look at the outcome levels across the groups they were comparing. So this is like a graph I made in Excel. And it's just the prevalence of uncontrolled high blood pressure among people with hypertension in NHANES over the 20 years, I think, before that study. And so, you'll see that the prevalence of uncontrolled high blood pressure was kind of highest in the Mexican American population and maybe the non-Hispanic Black population in more recent years. It was never the highest in the non-Hispanic white population that they're proposing to target for intervention. So theoretically, if somebody took their recommendation seriously and successfully targeted the non-Hispanic white population for improvement in their diabetes care as a way to reduce uncontrolled blood pressure, while care remained the same for Blacks and Mexican Americans, we would expect white rates to drop even lower and for disparities to increase. And so noting current group differences in the outcome and projecting how the targeted intervention would affect the group differences is an important consideration when you're making recommendations about targeting groups. So the second question we say to ask if you want to do intervention-oriented health disparity work is to ask, is the distribution of the exposure that you're proposing to manipulate greater in the target group versus other groups? And so this is something that is actually overlooked quite a bit. And I'll talk a little bit about that more. But we kind of use a series of diagrams to try to emphasize this more. I think so much of work in epidemiology is giving you coefficient terms from a regression model. And so in this graph, the slopes of the lines, the angles of the lines are kind of representing that. But we also added these circles to try to say who has more exposure and who has less exposure. And so here in this graph, we have two groups. Group A is kind of in blue-green, and group B is in red, which are not good colors for colorblind people. So group A is kind of the top one that's angling up more. And so to understand this figure, just assume you have a dichotomous exposure in two groups you're examining. And the lines are representing results from just a stratified analysis of the association between some exposure, some harmful exposure, and some harmful outcome. And so in this example, in each group, the circles are the same size. So all four circles are the same size. So 50% of the people in group A are not exposed, and 50% of the people in group A are exposed. 50% of the people in group B likewise are not exposed, and 50% of those people in group B are exposed. And so again, the authors have argued that we should improve diabetes care for the non-Hispanic white population because diabetes increases the risk of uncontrolled blood pressure in this group. And so when we think about targeting a group, we argue that it's important to ask whether the risk-producing exposure, the harmful exposure, is more prevalent in the group that we are targeting, because we're trying to reduce that in that group. Is it more common in that group that we are targeting over other groups? And here the answer is no. So this is just their table one. You can get so much information from a table one. I love dissecting people's table ones. And so these are just age-adjusted characteristics of the subjects with diagnosed hypertension. This is the group we're limiting to, and looking at diabetes, our exposure, and then stratified by these three racial groups. And so you'll see that the non-Hispanic whites, who they are saying to target to improve and decrease their prevalence of diabetes, their prevalence of diabetes was 22% approximately. In the Mexican Americans, who they're leaving aside, the prevalence was 42%. And in the non-Hispanic Blacks, the prevalence was 38%. So I kind of made another graph in Excel, a chart this time. So just to emphasize that, again, here the diabetes prevalence is much less common among the non-Hispanic whites in the population and then the non-Hispanic Blacks and Mexican Americans. So if they effectively targeted reduction in diabetes, it would increase disparities in the outcome, which is uncontrolled hypertension, and increase disparities in this exposure burden of diabetes. Another way to represent this difference in exposure burden here is kind of this graph that I'm going to show again. So I'm just trying to emphasize that if I'm looking at that top line, which is representing the Mexican Americans, a greater proportion of that population is in the diabetes group. They are more likely to be exposed. This is stylized. And in the non-Hispanic white group, a relatively greater proportion are in the no diabetes group. And the size of the circles is just emphasizing this exposure. And so again, based on examining the disease burden of uncontrolled hypertension, the group that choose to target non-Hispanic whites are not more at risk of this outcome. And also the exposure burden of diabetes is also less in the group they choose to target than non-Hispanic whites. And so far, there's not really any justification for targeting this group, especially considering that they are not a socially disadvantaged group. But there is one final question that we say that people should think about when they're trying to identify causes of health disparity. And that's whether the association between the exposure, in this case diabetes, and the outcome, in this case uncontrolled blood pressure, is greater in the target group versus other groups. And here we're finally starting to see maybe where these recommendations are coming from. This is actually stratified models, but I'm just kind of giving you the stratified model slopes. So just thinking about the odds ratios for diabetes and uncontrolled blood pressure in each group, the relationship is about 2.6 in the non-Hispanic whites, about 2.4 in the non-Hispanic Blacks, and only 1.6 in the Mexican Americans. And you can kind of see that in my stylized graph. So the Mexican American line is above the non-Hispanic white line, whether they're exposed or not, comparing to non-Hispanic whites with similar exposure. They have more uncontrolled blood pressure, but kind of that slope of the line, the difference in the risk of uncontrolled blood pressure between those with diabetes and those without is not as great in the Mexican American population as in the non-Hispanic white population, at least on the odds ratio scale. It's a whole nother thing. We're ignoring scale issues. And so, like you can see this. You can see a population where overall they have more uncontrolled blood pressure. More of the people are in the high-risk group, but the difference in risk between the exposed and unexposed is less in the Mexican American population than the non-Hispanic white population. And so the coefficients for diabetes in these stratified models are just indicators of slope. And when you're not running stratified models, it's really popular to just include an interaction term as an indicator of whether the slopes differ across levels of another variable. And I think this is how we ended up getting to our counterintuitive final sentence. It is because of the seduction of the interaction term. The interaction term is very seductive. You should watch out for it. And just keep an eye out. Because, I talked kind of at the beginning about kind of these things you need to do good epidemiology. And one of them is to be specific about your questions. And I think this group probably was like, there's probably something about race. I know it's important. I have this variable here. I don't quite know what to do with it, but I think I should investigate it. And maybe I should put it in an interaction term. Like maybe I should see if the exposure and race have an interaction. And like, here are the interaction terms. The interaction term for Mexican Americans was statistically significant because as we saw, that slope was a lot less for this population than the other populations. And I think this is how we get to the heart of this head scratching recommendation. I think it really hinged here on the interaction. The fact that the odds ratio for the diabetes hypertension relationship was steeper among non-Hispanic whites than the other groups. And again, I'm not trying to pick on these people because I feel like I see this a lot. People will look at what the statistical software spits out at you. And I think that can be very dangerous because you're like, well, this seems like it has some of the factors of interest that I care about. And like, here's a p-value, and maybe this is answering my non-specific question that maybe I didn't frame that well. And, you know, like, again, so many of these things seem like pedantic, things that your like epi teacher like quizzes you on, and it seems super boring. But the implications are landing on a conclusion that you should target non-Hispanic whites for better diabetes control, even though they have less diabetes and less hypertension. And that's just like not where you want to end up. And you don't want to end up in a situation where a health burden is greater for a population of interest and the risk factor is more common for the community of interest, but you end up arguing that you should focus intervention efforts on improving the care of the less burdened population. I'm wrapping up my talk. I thought I would kind of start sliding into the next talk. You have John Jackson talking to you about mediation analysis. This is very basic. And he like has a whole framework that's much better for thinking about mediation analysis. But I think a lot of people in health equity are attracted to it because mediation analysis, one thing it does is that, you know, it slices your analyses up into effects that kind of map on to some of these guiding questions. So when you think about a standardized total effect, that's kind of getting at that first question about like, who is the outcome burden higher in? And when you get some of these disparity measures, like indirect effects, it ideally is incorporating not just kind of the slopes, but also the distribution of exposures. And so I think that's one reason that these methods are of interest to people, although they're still very much in development. And sometimes I think rely on heroic assumptions that are not met. So I don't think everybody should just go out and do a mediation analysis, but I think it's an interesting theoretical framework to think about. And John will tell you much more about it. He's very smart. And so, you know, I don't know whether the question that was asked here was important, but I think being in groups like this that are interdisciplinary and hearing all the things people are thinking about in terms of what is producing health outcomes is super important because it gives you a wide view of the kind of questions that could be asked, and it gives you context for the questions you are asking and a better choice about how to ask a good question. I think asking specific questions is vital if we want the work to be informative in an intervention-oriented context. And I think working with people who can help you do analyses that actually answer your questions and where you can interpret the results in a way that's accurate is very vital for this kind of work. And again, like, I love this work. I think it's super intellectually engaging, and I think there's a lot of potential for really strong interdisciplinary work to move the field forward and come up with insights that actually like help move the needle. Thank you.
So much, Dr. Robinson. We're going to open for questions. Okay, we're going to open up for questions from the audience, and also there's already a question in the chat. Just want to say we are running a little bit behind, but we are going to take our 10-minute break. Dr. Jackson is on the line, and he's okay with that. So, but I wanted to pause. Maybe we can take 10 minutes of questions, Q&A right now, before we take our break, okay? So let's start with a question from the room. Anyone? Oh, whoa.
Thank you. Thanks so much. This was awesome. And I loved your paper. I think my question has to do with the sort of availability of the data on, let's say, exposure prevalence. and even sometimes outcome prevalence. So in absence of prevalence data on certain types of exposures or outcomes, what would you recommend us do? Like, let's say we're trying to study a new social determinant of health that hasn't been widely studied, we don't have population level data on it. How would you approach that?
I'm always going to plug improving resources for better surveillance. I feel like our surveillance system, I think a lot of people have found out, it's like in the US is pretty terrible. And there are a lot of people here who do like measurement research and who are really trying to push forward with more representative sampling of important concepts. I mean, I think there's people here specifically, like I think about structural racism, which is a concept that people are more and more interested in. And a lot of the work now is like, let's think about measurement, let's think about data collection, let's think about building constructs. But in the meantime, in the absence of that, I don't know, sometimes I use proxies, sometimes I use like weird study designs. I really like using weird study designs. I love a study design that's like, if this is true, then this is what we'd expect to see in the data. And if it's not true, we would expect to see this other thing. It's kind of indirect, but it takes some brainstorming sometimes, but sometimes it's kind of imagining, okay, what do I think this world is like? And trying to ask questions to triangulate around a question when you can't get at the specific estimate that you want. I don't know if anybody else has any other ideas.
And I don't mean to stir the pot.
Okay.
I got my big spoon. This is what I emailed Dr. Robinson, and I got.
I didn't get her email. Yes.
So I asked her, what if we think of disparities in the wrong way? We often think of it as a deficit on the minoritized community. But based on theories of structural racism, the system is supposed to discriminate. It's supposed to disenfranchise. So that's the norm.
Yeah.
The sort of poor health of minoritized communities is normal. So what we might be capturing in a disparity is sort of the way that white people have sort of taken health and benefited. So how can we reconceptualize the disparity in these kinds of ways? And then I also will add to that, maybe white people lie about some of their outcomes. And so the disparity is there because they know how to answer the question.
Just on your second part, I used to do a lot of obesity research, and like self-reported BMI, this is definitely an issue with like white women's pattern of underreporting being really different. And so like, it's really interesting to look at obesity prevalence in the Midwest from self-reported versus measured data. And it's really different. So like, yes, totally. I love that you asked this question. I totally agree. So actually, this is one of the things I kind of want to write about because I see more and more people saying like we should interpret the coefficient for race as racism. And I actually don't like that because I actually think racism is like part of it, but not the whole of it. I'm actually really interested. So there's a paper by Pat Sharkey about crime in the 90s, maybe in Chicago. And it basically looked at community organizations and the density of community-led organizations in relation to crime, and just showed like a super powerful effect. And it just makes me think about agency and autonomy and resistance, because I think that this frame does have a way of making marginalized groups seem like passive recipients of racism or passive recipients of disadvantage. And that is not actually the way it works. People care about their health. People resist. People do community things. They take care of their families, like they give so much. And I actually really love decomposition because it incorporates that, because decomposition can flip, right? Like I actually think a lot of our measures underestimate how bad structural racism is because it actually implicitly incorporates all the resistance and internal like care work and resistance that communities are doing. And I do feel like we're at a point where we haven't really strongly conceptualized that. I think the next step beyond racism, not race, is also the incorporation of structures of like self-advocacy and resistance and positive health promoting things that communities are doing all the time that are totally undercounted.
Thanks, Whitney. I appreciate the work there. I felt that. I have a question, a follow-up question, which is an excellent question. I actually put some notes here about the framing of disadvantaged people experiencing poorer health versus advantaged people experiencing better health. And I guess that kind of ties into my primary question, which is kind of at this point where we understand a little bit of the effects of structural discrimination, racism, et cetera, on health. How important is it to keep establishing for every exposure, every outcome that this exists across different groups, and whether our questions should be shifting more to kind of capturing what was just described, that there's also something else going on the other side of this. It's not just disadvantaged groups and suffering poor health, but advantaged groups experiencing better health.
Yeah. Jen gets to run up with the microphone. No, it's actually work that I think is important. And I do feel like it's kind of like nascent. And I mean, I think also our funding agencies are not set up to capture it. Like our funding agencies are very like disease deficit oriented, and even epi, like you're identifying your risk factor. Like I've done some work about protective factors and it just like confuses people. They're like, why is this OR less than 1? Like what's happening? And so I think a lot of our frameworks for how we train and also how we do funding are literally not set up for this kind of work. And so I think it's going to take researchers like pushing back to like flip some of these paradigms. I do think that there is some potential with maybe decomposition. So we'll see about that. I don't know if that answers your question, but yeah, I think there's a lot that can be done. Yeah.
Thanks so much. Because I really agree with you about like not really liking having race and racism, but know that there's a lot of variety in how people take our imperfect data to our research questions. Can you just give some tips of like how to like dialogue compassionately when we like disagree?
Yeah. You can walk slow. I need some time to think about this. And so the question was about like, if you are in a setting where you are thinking like about this race is not just racism or some kind of a marker of the deficit of the group, if they, have observed worse health outcomes, like how do you talk about this and engage with people and try to like disagree when people are thinking about it more in that deficit framework? I really do need to think about it. It can be tough. Sometimes people are very entrenched. I don't know this field that well, but like I have worked in some fields, like I used to work in obesity, and it is a field with a lot of dogma. Like there's some fields that just have a lot of dogma, and it is very hard to shift kind of the questions people ask and the way they see things, even if it seems obvious. And some of that is about power dynamics, about who controls research agendas in different fields. Some of it's about funding. And I mean, sometimes, an honest answer is sometimes you shift. Like there are times when I have actually kind of shifted my research because I'm like, I don't think I can make headway in this area because the dogma is so thick and people are just not open. Sometimes you can kind of nibble around the edges. Like I think a lot of social epidemiologists are good at this because we're like, we really want to study like structural things, but NIH like has not cared. So like I'll say I'm doing this and I'll do this thing, but like really I want to do it to kind of sideways understand this other thing. So I think sometimes you can use subterfuge. And I think people are curious, but it takes time. And I think sometimes you have to decide who am I going to invest in. Sometimes you can give somebody a paper, and sometimes choosing the right paper can be difficult. It can actually be a really hard conversation. It's really sometimes hard for me when I'm talking to somebody who's extremely smart, very methodologically rigorous, but there's just a gap and some basic conceptual point. And sometimes it's hard for me to even identify what the gap is. Like I don't sometimes know how to bridge it because I'm like, I know you're smart, I know you care, but like, there's a gap there. So sometimes asking questions to try to understand, like, how do you understand this thing, can help identify what's the point of disjuncture, and trying to think about the right literature that might speak to them. I don't know. I welcome other suggestions.
Okay, I don't see any hands shooting up, but I think we should now, Greg. This was amazing. Thank you so much.